So we have with us today Dr. Shreya, who is the presenter of this case. She is a resident at Vedanta Medical College, and our moderator, who is an expert in uveitis, Dr. Mayur Morekar. Now, Dr. Mayur Morekar is an ophthalmologist with special interest in ocular inflammation, immunology, uveitis, and neuro-ophthalmology. He has done his training from LV Prasad, and additionally, he has a master's degree in counseling psychology and a postgraduate diploma in healthcare and medical legal system management. And he is also a fitness enthusiast and works as an associate professor in of ophthalmology at Bombay Hospital Institute of Medical Sciences, Mumbai. So we welcome Dr. Morekar. So I think you can go ahead with the session, and Dr. Shreya, you can share the slides.
Thank
Yes,
you
sir.
very much, Dr. Anish.
అటువంటి ఏంది should we start?
Yeah, please, Dr. Shreya, you can start.
Good evening, everyone. Today I will be presenting a case presentation on ocular toxoplasmosis. So, chief complaints. A 25-year-old female came with the chief complaints of diminution of vision in right eye since 10 days and floating black spots in front of right eye since 10 days. History of presenting illness. My patient was apparently all right 10 days back when she started experiencing diminution of vision in right eye, which was insidious in onset, gradually progressed to present condition, and painful in nature. It was associated with floaters, which were 2 or 3 in number, and not associated with limiting or relieving factors, for which she also got treated elsewhere with diflupride. No history of itching, watering, or discharge. No history of colored halos and headache. No history of pain or eye movements. No history of fever, chills, night sweats, wet loss. No history of any joint pain, low back pain. No history of cough, hemoptysis, dyspnea, recurrent upper respiratory tract infections. No history of headache, numbness, loss of consciousness, tingling, weakness. No history of diarrhea or bloody stools. No history of any skin rash, white patches, or loss of hair. Past history. No history of any similar complaints in past. No history of trauma or any blood transfusion in the past. The personal history. Sleep appetite, bowel and bladder are normal. Patient has recent exposure to cat at home and no history of any miscarriages or abortion. Ocular examination. The patient presented with 6/36 vision in right eye and IOP was 31 mm of Hg in right eye. Here's a video in which we can see the findings. So, as we can see in the video, anterior segment examination, lids are normal. Conjunctiva has mild circumcorneal congestion. Cornea, fine to medium keratic precipitates were seen. Anterior chamber was normal in depth. Iris not appreciated due to dilated pupils, and lens was clear. Then posterior segment examination. Vitreous case was present, which is suggestive of mild vitritis. In fundus, optic disc was normal. Corpus to disc ratio was 0.3. Foveal reflex was dull. Blood vessels, vascular sheathing was present, which suggests of vasculitis. In periphery, we can see two focal fluffy white lesions seen along with necrotizing retinochoroiditis in inferotemporal quadrant, which is suggestive of headlight and fog appearance. Then diagnosis. A 25-year-old female suffering from painful red eye with raised intraocular pressure, presenting with fine to medium keratic precipitates, suggestive of pan-uveitis, along with vitritis, vasculitis, and focal area of retinochoroiditis, might be suffering from ocular toxoplasmosis.
So, Dr. Shreya, only on this much, what other pathologies would you think of? One of them is obviously ocular toxoplasmosis. Is there something else that you will think of?
Sir, it can be acute congestive glaucoma since the patient has raised IOP and is presenting with acute red eye, and inflammation is also there. So, but fundus findings are not corresponding to glaucoma. So,
Okay. What
and
do you
yes,
think in this case is the cause for the raised IOP?
sir, I cannot hear you properly.
I said, what do you think in this case is the cause for the raised IOP?
Sir, ciliary spasm, because of ciliary spasm and um,
Okay, fine. We'll answer this later. You can just go ahead.
but, yeah. Then investigations. Investigations, we would like to do OCT for complications like epiretinal membrane, vitreomacular traction, retinal detachment, or choroidal neovascularization. Fundus fluorescent angiography or indocyanine green angiography can also be done for complications. Diagnostic tests for toxoplasmosis are serological tests in which we can identify the IgM antibodies like Sabin-Feldman diet test, which is the gold standard test. We can do PCR, that is polymerase chain reaction, in which we can find Goldman-Whitwer coefficient, and complement fixation test, heme agglutination assay, or ELISA can also be performed. Then treatment. We can start the patient with pyrimethamine with loading dose of 100 milligram on first day, 75 milligram on second day, 50 milligram on third day, followed by 25 milligram daily for 4 to 6 weeks, along with sulfadiazine 4 grams daily. Then we can give patient systemic steroids 48 hours after stopping the antiprotozoal treatment like pyrimethamine and sulfadiazine, and steroid should be stopped 10 days before stopping the antiprotozoal treatment. If the patient is allergic to sulfa drug, we can give her clindamycin or azithromycin. And for treating the anterior uveitis, we can give patient topical steroids and cycloplegics like atropine. And recent studies have shown that trovafloxacin and intravitreal clindamycin, melatonin or zinc can also be used in cases of toxoplasmosis. If the patient is pregnant, then in first trimester, we can give spiramycin plus sulfadiazine. In second trimester, we can give spiramycin, sulfadiazine, pyrimethamine, and folinic acid. In third trimester, we can give spiramycin, pyrimethamine, folinic acid. And in newborns, we can give sulfadiazine, pyrimethamine, and folinic acid.
Okay, fine. So the way we take it now is you go back to the first slide. Okay, come here. Okay, go to the second slide.
Yes, sir.
Fine, go to the third one. So come to the second slide again. Now, the question that I had first asked was, why do you think is the intraocular pressure raised?
Yes, sir.
Is anyone there who can answer this? Dr. Neeta has actually put it on the chat. But is there anyone else who wants to unmute and answer can do that?
I think anyone can take Swati, Preetha, Shambhavi, anyone, please.
So what happens in any uveitis is when you have raised intraocular pressure, you actually think of two or three things. The first thing that I think of is the angle open or close? Okay. Over here, very obviously the angle is open. When the angle is open, I think of two things then. Is the disease causing the raised intraocular pressure, or is the treatment of the disease causing the raised intraocular pressure? Okay. Here
Yes,
you see there are medium to large size, small to medium sized KPs which are there. Okay.
yes, sir.
There is a good possibility that there is trabeculitis, that is inflammation of the trabecular meshwork. And when there is inflammation of the trabecular meshwork, the meshwork will close and you will get what is like a secondary open angle glaucoma. Means the angle morphology is open, but because of trabeculitis, the aqueous isn't able to go out and the intraocular pressure will rise. Okay. So
Yes, sir.
that would be the most probable etiology here. The other thing is she has undergone treatment somewhere with diflupred.
Yes, sir.
Diflupred is basically difluprednate, and it is one of those topical steroids which is known to very easily induce a ocular hypertension in a patient who may be prone to be a responder to topical steroids. So that is the answer to the question. Okay. Uh, any time that we are talking, anyone wants to intervene, interject, say anything, they are free to do that. Okay. So go to the next slide. Yeah. So the next one. Now you have written over here history of exposure to cat at home. Now there is this history something that we ask all our OPD patients?
Not all over, sir.
Yeah. So why have you asked that history to this particular patient?
So because we were suspecting uveitis and pan uveitis, so toxoplasma is most common cause. So and intermediate host of toxoplasma is pets like cats and dogs. That's
Yeah.
why I have
Yeah.
asked this.
Yeah. So that is a correct answer. Now we go one step ahead to try to understand that in uveitis, history taking happens twice. The first time the history taking happens is when you take the history like you would take in any other patient. The second time it can happen is a retrospective history, means now I have examined the patient, I can see that headlight in fog, I can see all that, and then I go back and ask the patient that is there a history of exposure to cats. Okay, so the point to be made here is that in the management of uveitis, you may sometimes not take the entire history in the beginning. You can take a very selective history after seeing the examination. So if you see small KPs, acute anterior uveitis, you can go and ask the history of lower backache. If you see a clinical picture that's suggestive of tuberculosis, large granulomatous KPs, okay, then you can go back and ask for history of Cox or Cox contact. That's why. So the point is that many times in uveitis, you don't take the history upfront. You will take what is a retrospective history. Okay, now go to the next one. So this is a very beautiful video. So you can just play it again. So very beautiful. You can see these KPs. Now, if you see the KPs here, they are not present superiorly. They are more present inferiorly. Keep running the video. Okay. And you see that they are medium to large sized KPs. Okay. And when one sees medium to large size KPs, just halt the video. So when one sees medium to large size KPs, what are the things that one thinks of? If you see this clinical picture, what would you think of? One, you said you would think of toxoplasma. Are there any other things that one you would think of?
And the posterior,
So
in anterior uveitis, like
yeah. So if someone is answering that question, that person can unmute and answer.
Granulomatous uveitis, sir.
Yeah, absolutely. So whenever you see KPs, you first think whether this is granulomatous or non-granulomatous. Non-granulomatous KPs are basically going to be small, fine KPs. Granulomatous KPs are going to look something of this sort. Okay. So when you are seeing granulomatous KPs like that, you start thinking of, in the Indian setting, first tuberculosis. Okay. Then you think of sarcoidosis. You will think of toxoplasmosis. You will think of a viral etiology, and you will think of Fuchs heterochromic iridocyclitis. So if I see only this much, then these are the 5 things that will come to my mind. Okay. Now you combine with that the history that the intraocular pressure is 31, then I think of those causes of granulomatous uveitis that can raise intraocular pressure. Okay. So basically, inflammation causing rise in intraocular pressure, which is basically called hypertensive uveitis. So can anyone name 1, 2, 3 causes of hypertensive uveitis? One is, of course, toxoplasmosis. The other, there are
sarcoidosis.
sarcoidosis, and the third is viruses. Okay.
Virus.
So viruses will cause that. So when you see that, that comes to the next thing comes to mind. Go ahead then. Play the video. So now you see that lesion there. You see the disc is healthy, and you see that lesion which is seen in this video is seen upper. That means the lesion is niche, inferotemporal. Okay. And I don't know whether you can, whether that's a little scar over there, but you can see 2 lesions distinctly. Now halt the video over here. Yeah, halt it over here. So what are you seeing over here? Can you just tell that description again? You said fluffy white something.
The two fluffy white focal lesions of retinochoroiditis.
Uh, Now you said retinochoroiditis. Why did you not say chorioretinitis? Or why did you not say choroiditis? Or why did you not say retinitis?
So because both are involved, and
So how do you make that out? So after this class gets over, everybody should go back, open whichever textbooks they are reading. I used to study Kansky. So in that you look at tuberculous choroiditis. Okay. And when you see tuberculous choroiditis, you see, are you able to see the retinal vessels? And you will realize that you are able to see the retinal vessels going above the whatever yellow that you are seeing. So that means that the lesion is mostly deeper to the retina. But here you can't see the vessels. Okay, that means this is mostly involving the retina. Number one. Number two is you see that right in front of that area of yellowing, there is some vitritis. Okay, so in both these lesions, if you see maximum vitritis is just pre-retinal. Okay, so that's the second reason that this will be a retinochoroiditis. choroiditis. Okay. And the third one, go ahead, run the video. So as you run the video, is the video over now?
Yes, sir.
Yeah. So in your description, you have written vasculitis.
Yes, sir.
Okay. Now, can you just elaborate a little more on that?
So, in the start of the video, we can see the whitish linings
Whitish
around the
linings.
vessel.
Yes, yes.
That is
So
known as
those whitish linings, those lines are arteries or those lines are veins?
arteries.
See again. You have to share your screen again. Yeah, you can wait here. Okay. Now, see, very frankly, I cannot make out very clearly whether these are arteries or these are veins. But in real life, when you are looking not at a video, but you are looking at the actual patient, it will make sense trying to trace back those vessels to the optic nerve to try to see whether primary involvement is in the veins or in the arteries. This is important. Why is it important? Because syphilis will affect arteries. Toxo will affect veins primarily. Tuberculosis will affect veins primarily. Okay. So when you say vasculitis, it may be a good idea to actually see which one is involved and say whether it is a periarteritis or a periphlebitis. Okay, so when the moment I say periphlebitis, everybody thinks of TB, sarcoid, right? So that description you should try to make.
Yes.
Okay. So Dr. Anuj is playing that video for us. And this is where you can see that.
So it's slightly better quality, so I
Yeah.
thought to just share.
Yeah, yeah. Okay. Fine. So we can come back to the presentation. Shreya, you will have to share screen.
Yes, sir.
So go to the next slide. Okay, so you've done this description. Go to the next slide. Go to the next one. Yeah, so here you are giving the entire description. So this is where I had actually commented that what else can it be other than toxoplasmosis. So now do you want to change your answer? You want to add a few more things?
Sir, it can be viral retinitis and acute congestive glaucomas. It can be syphilis.
Yeah.
It can be any fungal etiologies.
Uh,
And it can be sarcoidosis, ocular tuberculosis.
okay, so it can be any one of them. Okay.
Yes.
Now, why is it not acute congestive glaucoma?
Sir, in glaucoma, we have these changes are not there, and visual field defects will also occur. Which are,
KPs are there, na?
yes, sir.
हाँ, so basically तो नहीं है ना पूरा, you know it's not an acute congestive
Yes,
glaucoma,
sir.
so it's not. Why do you think it is not viral? Why did you not say viral first?
Sir, in viral arteries and veins are more involved other than
So in
and
virus, na, there are only, just remember two things. Either you will see this type of white in the periphery
yes,
and going circumferentially, okay, or you will see it beside the optic nerve with a lot of red. Okay, so in the periphery going around is acute retinal necrosis.
yes,
Beside the optic nerve coming this way, okay, is that CMV retinitis. तो फिर ये दोनों में से कोई नहीं है, तो वायरस भी गया. Okay, now you said syphilis. Okay, so that is one thing that can be there in my mind. Okay, syphilis हो सकता है. Then you said sarcoidosis and you said tuberculosis. Okay, so
yes,
in my mind, those two are there. So I am right now on 4 diagnoses. This can be TB, this can be sarcoid, this can be syphilis, this can be toxo. Okay, so
yes,
4. Now go to the next one. So now I have to do something for the patient because patient is in front of me, right?
yes, sir.
Now, out of these, which one of the investigations is going to help me exclude the other 3?
The serological test.
Serological test is one thing, and okay, so see, all these are tests which you have written, fine. Those are for completeness for of the presentation. But in patient is front of you, what tests are you going to write?
VDRL, sir.
VDRL, okay. Then
Montauk's test for
1, 2
tuberculosis.
test. Then
Sir, torch infections. Test for torch.
okay. Then सार्कॉइड के लिए क्या लिखोगे?
Sir, ACE inhibitors.
ACE,
Serum
okay.
ACE inhibitors.
Serum ACE, then
X-rays.
X-ray, chest,
Chest
okay.
X-ray.
PA view, then I think this much is enough, na? There's one more thing that you should write. One more test. See, I'll tell you, all this that we talk about, uveitis specialist, is all based on just one assumption that we know how the organism is going to interact with the immune system. So
Yes.
we need to know what the immune system is like. Is the immune system competent or compromised? So what will you ask for?
Yes.
CD4 count.
CD4 is thoda aage ka, but would you ask for something else before that?
So ESR,
ESR is one thing, yes. Then
C-reactive.
CRP, yeah. Okay, then okay, see, we will go by all the investigations. We'll ask for CBC, we'll ask for ESR, we'll ask for CRP, we'll ask for Mantoux test, we'll ask for ACE, X-ray chest. All these are for TB only. Okay, so you understand how much TB is on our mind. Okay, then we'll ask for VDRL, you said. Okay. Personally, I would like to ask for TPHA, not VDRL, when I'm thinking of syphilis. Okay.
Yes.
And then you said CD4 count, but I would like to inform the patient and ask for HIV.
Yes.
Okay. Now, there are two things that I would not ask for. One is torch. Okay. So serological test is something that we really don't ask for from the point of view of making a diagnosis. Okay. Over here, you know you are dealing with toxo, so you may ask for toxo IgG, IgM specifically, but you don't ask for the entire torch. ना? So वो एक हो गया. And someone wrote ANA in the chat box. So ANA is something that does not have so much of a role in adult uveitis. It is something that has a role when you are talking of JI, juvenile idiopathic arthritis. So यहाँ तक आया, these are the investigations you have asked for. So now you realize out of all the investigations you have asked for, there is just one that is for toxo. The other all are to rule out TB, to rule out sarcoid, to rule out syphilis. So is this a diagnosis which you are going to make on the basis of investigations, or is it a diagnosis that you are going to make clinically?
The
Toxo.
diagnosis exclusion.
It's not diagnosis of exclusion. It is a diagnosis that you will make when you see it. When you see that retinitis with overlying vitritis and that headlight in fog, think of toxoplasmosis. That is going to be the first thing. Why this is important is because each of these tests that you have asked for is going to take at least 2 days to come. Okay. And in 2 days, you have to do something for the patient. You can't be waiting, right? So that is why you should know that this is something that you will treat clinically. Okay. So go to the next slide and wait there. So here, before we decide on what is going to be the treatment, my question is, do you treat all patients of toxo? As per textbooks, are all patients of toxo to be treated? Or are there indications, specific indications where you will treat? So I'll change the question. Is there a chance that you can leave a toxo alone and not treat it?
Yes, sir. In some patients, we can do observation
Yeah.
and the
So which
lesion
are
will be-
those? Which are those in which whom you can observe? Or conversely, which are the those in whom you will definitely treat?
The active lesions we have to treat, and
Active disease, okay, that may be one. Second, Shreya, just stop sharing for 1 second. I want to share my screen. Just so this is, you can see that on the right. In this right eye, there is this lesion here. Okay, will I treat or will I not treat this? That's close to fovea, right? So you will treat. So active lesions, you said one. Second is lesions close to fovea. Then third, think of vital structures in the eye. No? You don't want vital structures to get damaged. One is the fovea. What is the second vital structure?
optic disc.
Optic disc. So peripapillary lesions, you will want to treat. Okay. Fourth, ये हेडलाइट इन फॉग है. अगर बहुत ज्यादा फॉग है, पेशेंट का विजन बहुत ही कम है, तो
Yes,
यू
sir.
विल ट्रीट ना. यू वोंट से कि अरे टॉक्सो है, आप जाओ, आप ठीक हो जाओगे. राइट.
Yes.
सो basically it's very simple. You treat peripapillary, perifoveal, parafoveal, very active disease, meaning those in which there is too much fog. Okay. Now share your screen, go to that slide where we stopped. Now see, you have written the treatment very beautifully as per textbook. But in real life, which is the drug that you use?
So mostly we use azithromycin.
Azithromycin is one thing that you use. I like to use azithromycin because I am allergic to the other drug. So which drug I may be allergic to?
Sulfur drug, sulfadiazine, sulfamethoxazole.
Sulfamethoxazole is not pyrimethamine. It is neither sulfadiazine. Sulfamethoxazole is something else. Okay. So sulfamethoxazole is a part of which fixed drug combination?
Cotrimoxazole.
Yes. Okay. So what is that fixed drug combination ka dosage? Can someone say? Someone said that, no? Cotrimoxazole is what? Sulfamethoxazole and
Trimethoprim.
trimethoprim. And what is the fixed drug combination? Sulfamethoxazole is 800 milligram. Trimethoprim is 160 milligrams. Somebody, a madam is over there. Tablet, Septran. Okay. So that will be mostly the drug that you will use. Why is that the drug that you will use and not pyrimethamine and sulfadiazine?
Low
Basic,
cost.
low cost, easy availability, and so go to the next slide. Your answer is there in the next slide, Shreya. अच्छा एक बताओ तुम कहाँ पे? Okay, you haven't written it. So you are supposed to substitute something over here when you are using this combination. What is that? You are supposed to substitute with
Folinic.
folinic acid. See, you have
Yes.
written over there.
Yes.
Folinic acid. Folic written is that folinic acid. Yeah, this has got effects. This drug that we don't very commonly use. We more commonly use the other drug, that's Septran or Bactrim. Okay, fine. Now go 2 slides back. You are talking of other options which are there. So which are the other options that you have? Previous slide you have written. So patients allergic to, the next slide. Patients allergic to sulfa drugs, you are using what?
Clindamycin or azithromycin.
Clindamycin or azithromycin. When you are giving clindamycin, what do you want to be careful about? Anybody can answer. Clindamycin can cause something. It's one side effect. It causes what is called pseudomembranous colitis. Okay, so when you are giving clindamycin, you have to, along with it, give a lot of probiotics.
Yes.
Okay, about systemic steroids, what you have written is something that I agree with. Okay, so you start systemic steroids after starting antiprotozoal, and
Yes.
you stop it before stopping the antiprotozoal. Okay. Now, the other two drugs are something that I really don't have much experience with. Intravitreal clindamycin is one thing that you can use. Where does intravitreal clindamycin nowadays find a role? The answer is in your next slide.
Pregnancy.
Yeah. So in pregnancy, you are going to use it. Vertical transmission of toxoplasmosis happens in which trimester of pregnancy? More likely to occur in
First trimester.
first trimester. Okay. So that is the importance. If the mother gets the toxoplasmosis in the first trimester, you are supposed to treat it because there is a chance of a vertical transmission. Okay. Now go to the next slide. Thank you. Okay. So what are your doubts in this entire thing? First, we take your doubts, then we take the doubts of everybody else. So you gave the patient Septran or Septran DS twice a day. Your investigations have come, okay, and suppose the Mantu is positive, then what would you do? Mantu is positive, all other investigations are okay, and
गई वो पेशेंट नहीं
see, Mantu will come after 72 hours, right? By that time, there will be some response. No? So you will know if there is a response occurring, then you know that you are on the right track. Is there anybody else who has any doubts?
Yeah, I think everyone can use their mic so that we
You can just come use your mics.
and
Dr.
maybe turn
Nita
on your
Shanbag is
video.
there. Dr. Vaishali Ume is there. Anuj is there. Geeta madam, good evening.
So I think there are few questions what I have come to know. One is the duration of treatment. And that is a tricky this question.
Hmm.
The other they want to know is how long to continue steroids and how to taper.
Hmm.
So I think with the treatment part, maybe we can go ahead with this, and then if somebody has any doubt, then we can go ahead with that.
See, basically, as very practically speaking, I would most times see what sort of a response that I am getting with the use of the double strength Septran or Bactrim. Okay, I would also see whether this is a first attack or this is a recurrent attack. Okay, and I would also see what is the immune status of the patient. Now, if a patient is getting recurrent attacks, then the treatment is going to be long. Okay, and I'll tell you, with recurrent toxoplasmosis, treatments can be as long as about 300 to 350 days. Okay. So if you actually go search literature and try to find out what is the treatment of recurrent toxoplasmosis, then you will come to know that, and we have done this in a few patients to achieve actually what is remission. Okay, in patients who were recurring every 6 months, you have to give them this drug for about at double strength for about 2 weeks, then at single strength for about 2 weeks or 3 weeks, then actually make it alternate day, then actually keep it twice a week and continue. Now, the idea is that if you see how patients of HIV are treated, then you will realize that many of the patients of HIV, if you come across any HIV patient, see what their treatment is. and you will come to know what are the drugs of ART they use. And there is many times you will see in them that these patients are on tablet Septran twice a week. They take it on Monday, Thursday, or Sunday, Wednesday. So recurrent toxoplasmosis, you can go on that regimen and the treatment can be very long. So I would say as long as required to completely scar the lesion. Steroids will be for a very small duration. So basically steroids you are using because the fog is a part of this disease. So there is a lot of vitritis which is there. So you are using the steroids. So for me, steroids will be hardly for about 3 to 4 weeks, starting 48 hours after introduction of the antitoxoplasma. But steroids will stop early, 3 to 4 weeks, once you know the vitritis has settled. But the other part will go on for long. If it is the first time you are seeing a patient, okay, then, and if it is the first attack, then maybe your treatment will go for 3 to 4 to 6 weeks. But in recurrent cases, it can go all the way almost to 9 to 10 months. I think that is the correct answer from my point of view. I don't know, Anuj, what do you do? Anuj, you will have to unmute yourself.
Yeah, for me, steroids would be around 4 to 6 weeks. And yes, not in all patients, but sometimes, as described in when the lesions are threatening, because whether steroids they work or whether they are needed, this is one pathology which we don't know whether steroids are actually needed. So I think Dr. Morekar will guide us more, because this is not like tuberculosis where you can just start with steroids and maybe later add an AKT, because these are not immune mediated response. So in these cases, you should be very sure that you are starting the antimicrobial beforehand. Even if you don't start steroids, if you are unsure of the diagnosis, it is fine. But these cases are the cases where you don't start steroids before starting this. Like when we had discussed this case, a lot of people wanted to start steroids directly. So these are the cases where you don't start steroids, because if you put these patients just on steroids, or even if you inject steroids, then you may even lose the eye.
You see, for the benefit of all, there is this one thing that I follow, and which is very opposite what I would I would think I would do as a student. If I see a lot of vitritis, then it is very unlikely that I am going to start the patient on steroids. Because when I see a lot of vitritis, I am thinking of toxoplasmosis, I am thinking of acute retinal necrosis, I am also thinking of syphilis. And these three are infections. Like Dr. Anuj was trying to say, there is not much, these are not immune responses, these are direct infections. So when you see a lot of fog and something white in that fog, okay, that something white in fog is headlight in fog. And that white is in the mid periphery and something like a circle, then I would think of toxo. Otherwise, if it is far in the periphery, I will think of viral. And in both these, I will go and start the steroids straight away. So there is one thing that we need to all understand. Uveitis does not mean that we are going to start oral steroids right away if we are not finding a cause. So unexplained vitritis, one has to be very careful. There are many times they may turn out to be syphilis, many times they may turn out to be toxo or viral, or in elderly people, they may even turn out to be lymphomas. There is one question that I will ask, and anybody can answer. What is the role of deposteroids in toxoplasmosis? No controversies. It is a question that we can discuss at length. But what would generally people do? What would generally should be the guideline in relation to deposteroids? Deposteroid means triamcinolone or ozurdex.
Anyone, Rudya, would you like to take it?
Better to be avoided, sir.
Absolutely. Now, if I told you that there is a single lesion which is like toxo, and if I offered to you that can we give intravitreal clindamycin and intravitreal dexamethasone, would you go by it? Would you do it? Intravitreal clinda plus dexa. Anyone can
It
take that.
can be given, sir. But
See,
depot should be avoided.
deposteroid should be avoided, but clindamycin, ozurdex can be given. You see.
I think they thought about the dexamethasone
Dexamethasone.
injection rather than the dexamethasone depot injection.
See, I'll tell you one thing about toxoplasmosis is that treatment has to be systemic. It's better to go ahead with oral treatment than trying to resort to these injections, intraocular injections. That's because even if you open a very basic textbook like Kansky and try to find out what does the basic textbook say, you will realize that even the basic textbook will say that depots have to be avoided. That should be the norm. The only time that one should think of even intravitreal clindamycin is in pregnancy. For me, if I see toxo, I am going to try to treat it systemically. Okay. So I think that should be the take-home message. Deposteroids, like Dr. Udaya said, absolutely to be avoided. Okay. Unless there are a lot of reasons that you have, and so those are something, but those are exceptions. As a norm, deposteroids to be avoided. Even dexamethasone implant to be avoided. Okay. Clindamycin may be used, but it should be as an adjuvant. It should not be as standalone treatment. So you see toxo and we inject clinda, that should not be. You see toxo and you should start oral treatment. That's a good question. Can anybody answer that? How to differentiate toxoplasmosis and toxoplasmosis?
Shreya, you can take it.
So granulomas can be formed in toxoplasmosis.
You're right. But what I was telling, why is it so? So you are talking of the typical picture of Toxocara, right? The one which is there in the book. What is that picture like? Can you describe that picture? There is something in the periphery and there is something coming from the periphery to the optic nerve.
The vitreous band.
Yeah. So why is that? Why are vitreous bands present there and why not over here? It's just a food for thought question. There is no correct or wrong answer to this. So see, the vitreous is the reservoir where the immune system is going to come and play. So this is what I believe in toxoplasmosis. It is a more fast, acute sort of a thing. And that is a more chronic sort of a thing. Okay, So there you will get more healing that is occurring by secondary intention. So you will see all those vitreous bands and all. Here there will be intense vitritis, and so the patient will present to you with decrease of vision. Okay. And then you will treat it. And then that treatment will be by primary intervention. And when the lesion is such that it is going to self-heal, it's not going to induce so much vitritis. That will, in its self-healing stage, cause the vitreous condensation and vitreous bands. So how to differentiate the two? Differentiate the two on the basis of the clinical picture. This clinical picture is headlight and fog, and that clinical picture is of the peripheral granuloma and the vitreous band that comes to the posterior pole. Okay, so it's a clinical diagnosis, clinical picture. Anybody else has any doubt?
Yes, if somebody has any questions or want to make any comment, then we have Dr. Morekar for some time. Otherwise, we'll relieve him because he's busy in his practice and he has spared time for us. And it has been a lovely session, really. And I would say I was just watching a video of AIOS and I was surprised to say that the presenter was talking that oral treatment is causing a lot of toxicity and hence the intraoral treatment is the
Yeah.
drug of choice.
Yeah.
So what is your I think you have already
Yeah, I have.
here that but that was really surprising because with Bactrim DS so readily available and so this do you fear or do you counsel them for SJS ever to the patient?
Absolutely, absolutely. I do counsel them from SGS. In fact, there are two, I mean, it's just a sort of a informal chat that while writing two drugs, one is Bactrim DS and one is Dimox, I
Right,
always tell them that this can cause an allergic reaction.
right.
I am the sort of person, before I write timolol maleate also, I'll actually ask, asthma to nahi hai na? Because I am very, very, very mindful of side effects. So Bactrim DS is one drug that when I'm writing, I will definitely tell them that this can cause side effects. See, when you say that, they will be looking out for side effects and they will report them to you immediately. Okay. एंड इफ देर इज एनी क्वेश्चन के बचपन में कुछ साइड इफेक्ट हुआ था या कुछ भी ऑफ दैट सॉर्ट then you immediately resort to the other
Azithromycin.
azithromycin.
Shreya, anything you want to ask or you want to because you have made this case and beautifully presented.
No, sir.
Shreya is now well versed with toxo, so she can treat any case now.
Vaishali madam, thank you.
Yeah, it was really nice to have Vaishali ma'am and Neeta ma'am and even Shubha ma'am. So they're all our teachers and the greats from our medical colleges. So I would say that it is always a case of toxo is a little forgiving because it is a slow progressive case. So make your judgment. You can take your time, but just as you have rightly pointed out, don't miss a retinitis over a toxoplasmosis. So toxoplasmosis is a case where you can miss it. You can go wrong with the treatment unless you don't start a steroid, but that shouldn't be case with a case of a retinitis. And then this case, like you rightly pointed out, had a little bit of scar in the lesion. which was earlier, I think, was not very clear on the video, but there's a scar. So, and anything else? Anyone? Dr. Morekar, if you want to add something, it has already been extensive.
So thank you for having me here. Anuj, I have one doubt if I can ask.
Absolutely, absolutely.
Why those sunglasses?
That is just so that nobody comes to know that my reactions with the questions and this. So,
Okay.
Dr. Morekar, you can ask questions even for fitness, okay? If anyone has, because he's really, if you follow him, you will see his gait, and he is really a fitness enthusiast and an example. And recently, I think he has talked about fitness of doctors as a role model,
Yeah.
right? So that is which we tend to ignore. So that is one interesting, because that is practicing what we preach. So I think it was really great, and it was very nice to have you. And
Thank
we have covered a lot of points, and I think all of us will be now be in a position to better manage toxoplasmosis, and hope we can catch up again for a
Yeah.
different topic and again clear all our doubts. So I would like to thank once again Dr. Morekar and Dr. Shreya. So, and very nicely presented, Shreya. It takes some efforts to present in front of so many audience. And
Thank you, sir. Thank you.
yeah, we had a great
Thank you very much, sir.
turnout
Thank
of
you.
over more than 70 leads. So I think ma'am is also there. So
Okay. Thank you,
okay,
everyone.
okay, thank you, thank you. Okay.
Thanks a lot. Yeah.
Thank you,
Thank you.
sir.
Good night, everyone.